Welcome to our video on premature rupture of membranes, preterm premature rupture of membranes, operative delivery, and shoulder dystocia. Let's get started. Here's our overview slide. Let's begin with premature rupture of membranes, abbreviated PROM. PROM is the rupture of the chorion and amnion at term before the onset of regular uterine contractions. Patients describe a sudden gush of fluid consistent with leakage of amniotic fluid. The diagnosis of PROM occurs with a sterile speculum exam and investigation of vaginal fluid. Blue discoloration on the nitrazine paper after vaginal fluid application and the ferning pattern of fluid under microscopy suggests that this fluid is amniotic fluid, so the patient does have rupture of membranes. It's worth noting that a digital vaginal exam should be avoided in PROM to prevent chorioamniitis by introducing bacteria into the amniotic sac. Management of pre-labor rupture of membranes can be either expectant or active. Expectant management includes waiting for the onset of natural labor, while active management involves labor induction by oxytocin. Induction decreases the time from rupture of membranes to the delivery of the fetus and thus significantly reduces the risk of chorioamniitis and postpartum endometriitis. Therefore, labor induction by oxytocin is a preferred way of managing PROM unless the mother refuses to expedite delivery. Here we see a blue discoloration of the nitrazine paper, and this indicates a high pH of vaginal fluid ranging from 7 to 7.3. And again, a positive nitrazine paper test is characteristic of rupture of membranes. This is a photomicrograph showing the ferning pattern of amniotic fluid under microscopy. The ferning pattern, just like the positive nitrazine paper test, is characteristic of rupture of membranes. Preterm pre-labor rupture of membranes, or PPROM, is the rupture of the chorion and amnion at less than 37 weeks of gestation before the onset of regular uterine contractions. Risk factors for PPROM is a history of prior PPROM, antepartum bleeding, or genitourinary infections like asymptomatic bacteriuria and bacterial vaginosis. The diagnosis of PPROM occurs the same way as for PROM. Specifically, we perform a sterile speculum exam, we use the nitrazine paper test, and microscopy to look for a ferning pattern. The treatment of PPROM depends on the gestation week of the mother and the fetal status. If the mother is less than 34 weeks of gestation and the non-stress test shows a reassuring fetal state, then we can give latency antibiotics to prevent chorioamniitis, as well as betamethasone to accelerate fetal lung maturation. In contrast, if the mother is at less than 34 weeks of gestation, but the non-stress test is non-reassuring, we should perform delivery. In case of delivery at less than 32 weeks, we should administer magnesium sulfate to the mother to decrease the risk for cerebral palsy in a neonate. And if the mother is greater than or equal to 34 weeks of gestation, delivery is usually performed because the risk of chorioamniitis is greater than the benefit of keeping the baby in the uterus. Okay, now let's move on to discuss operative delivery, which includes cesarean section and operative vaginal delivery. We'll start by talking about cesarean section. Cesarean section is a surgery to deliver the baby. There are multiple indications for C-sections, including fetal distress, active phase arrest, macrosomia, and multiple gestation pregnancy. C-section is most commonly performed with a lower transverse uterine incision because it's aesthetically more acceptable for the patients and it's associated with minimal uterine scar formation. The trial of labor after C-section, also known as TOLAC, is permitted in case of lower transverse incision because the risk of uterine rupture is not very high. The second type of C-section is classical C-section, where we make a vertical uterine incision. If this has been done, then in subsequent pregnancies, TOLAC is avoided due to the risk of uterine rupture. Here we see the comparison between a lower transverse and a classic C-section. Hopefully you can appreciate that the incision is low transverse in the left image, while it's vertical in the right image. Operative vaginal delivery suggests delivery either via forceps or vacuum. Forceps delivery can be associated with fetal scalp hematoma, intracranial hemorrhage, and maternal vaginal lacerations. Vacuum delivery can also be associated with fetal scalp hematoma, vulvar and vaginal hematomas, and anal sphincter injury. Indications for operative vaginal delivery include maternal exhaustion and inability to push, maternal cardiac disease, and a prolonged second stage of labor. Here we see the comparison between forceps and vacuum delivery. Notice how, while using forceps, the baby is being pulled by the skull compared to vacuum, which performs suction of the scalp. All right, let's try a question. A 35-year-old G2P1 woman comes to the physician at 35 weeks of gestation for a routine prenatal visit. Her first baby was delivered via a classical cesarean section. Her vital signs in the physical exam are unremarkable. The patient wants to deliver her current baby vaginally. However, the physician recommends against the vaginal birth. What is the rationale behind the physician's recommendation for this patient? All right, this patient delivered her first baby via a classical cesarean section, and now she wants to deliver her baby via vaginal birth. Since classical cesarean section is performed via vertical uterine incision and leaves a significant scar in the uterus, a trial of labor after this is associated with the risk for uterine rupture. So there is risk for uterine rupture in case of vaginal birth, and this is why the physician recommends against this and instead would recommend a C-section. Okay, the last topic we'll discuss is shoulder dystocia. Shoulder dystocia is a lodged anterior shoulder under the maternal symphysis pubis after vaginal delivery of the fetal head. Most cases of shoulder dystocia are idiopathic. However, it can be related to maternal diabetes and obesity, causing fetal macrosomia. It can also be related to post-term pregnancy, which can also result in fetal macrosomia. Shoulder dystocia is commonly characterized by the turtle sign, and this is when the fetus retracts its head back into the vagina to relieve tension on its neck. This is an image showing shoulder dystocia, and notice that the anterior fetal shoulder is lodged under the maternal symphysis pubis. The treatment can be remembered with the mnemonic "be calm." The physician should instruct the woman to breathe and not push the baby. We should also perform the McRoberts maneuver. In this maneuver, we flex the hips and knees at 90 degrees to enlarge the pelvic outlet and apply suprapubic pressure. We should call for help because each leg should be flexed by one person. Then we apply suprapubic pressure to facilitate passage of the anterior shoulder. We may also need to enlarge the vaginal opening by performing an episiotomy. Finally, if the McRoberts maneuver does not help, we can perform other maneuvers, which we'll discuss in a moment. This is an image showing the McRoberts maneuver, and notice that the maternal knees and hips are flexed at 90 degrees, which helps enlarge the pelvic outlet. Okay, let's briefly review some other maneuvers which are also used in shoulder dystocia. The Rubin maneuver includes application of posterior pressure to the anterior shoulder to bring the baby in an oblique position. In the Wood's screw maneuver, on the other hand, the anterior shoulder is pushed towards the chest and the posterior shoulder is pushed towards the back. The Gaskin maneuver places the mother in an all-fours position with an arched back to enlarge the pelvic outlet. Finally, the Zavanelli maneuver involves pushing the baby's head back into the uterus and doing a C-section. Shoulder dystocia can be associated with many complications. For example, it commonly causes brachial plexopathy, which is usually transient. Although shoulder dystocia can cause both Erb's palsy and Klumpke palsy, the most common one is Erb's palsy. It can also be complicated by a clavicle or humerus fracture. A clavicle fracture can be intentional as well, because this can help facilitate the delivery of the anterior shoulder. Finally, shoulder dystocia can result in death due to fetal hypoxia. On this image, you can see a waiter's tip deformity characteristic of Erb palsy, and hopefully you can appreciate this adducted, extended, and pronated arm. All right, let's wrap up with a question. A 27-year-old G2P1 woman is brought to the emergency department at 39 weeks of gestation due to severe uterine contractions every 3 minutes. She has a past medical history of type 2 diabetes mellitus. Her pregnancy BMI was 30. Her vital signs include a temperature of 37 degrees Celsius, a blood pressure of 130 over 80 millimeters of mercury, a heart rate of 87 beats per minute, and a respiratory rate of 17 breaths per minute. The cervix is 6 centimeters dilated and 50% effaced. Several hours later, the fetal head is delivered. However, progression of labor stops due to an inability to deliver the fetal shoulders. Which of the following is the best next step in the management of this patient? A. Flex the maternal hips and knees and apply suprapubic pressure. B. Apply posterior pressure to the anterior fetal shoulder. C. Ask the mother to position herself in the all-fours position and arch her back. Or D. Push the baby's head back into the uterus and do a C-section. All right, this patient with a past medical history of type 2 diabetes mellitus and a pre-pregnancy BMI of 30 presents in labor several hours after the fetal head is delivered, but then the progression of labor stops due to the inability to deliver the fetal shoulders. This is a classic description of shoulder dystocia. So with this in mind, the best next step in the management of this patient is to perform the McRoberts maneuver. In other words, we should flex the maternal hips and knees and apply suprapubic pressure. Therefore, the correct option is A. Flex the maternal hips and knees and apply suprapubic pressure. This is the slide that we discussed earlier in the lecture, reminding us of the treatment for shoulder dystocia. As you can see, the McRoberts maneuver is the first maneuver that we apply to the mother in labor. All right, let's discuss why the other options are incorrect. Options B and C are consistent with the Rubin and Gaskin maneuvers respectively. The Rubin and Gaskin maneuvers are attempted only if the McRoberts maneuver fails, which is why these are incorrect. Finally, option D is consistent with the Zavanelli maneuver, and this is the last resort for managing shoulder dystocia. So again, the correct answer is A. Flex the maternal hips and knees and apply suprapubic pressure. And that concludes this section.